our next presentation on squamous cell carcinoma, and this is going to be a presentation from Dr. Nikhil Khushalani, our Vice Chair of the Department of Cutaneous Oncology, who will discuss the latest in clinical trials for squamous cell carcinoma. Dr. Khushalani.
Thank you very much, Dr. Sai. Are you guys able to hear me clearly?
Yes.
Okay, thank you very much. That was, a fantastic presentation by Dr. Arulu, very concise, to the point, and clearly highlighted the both the challenges as well as successes in basal cell carcinoma. So I'll try to do something similar for the second most common type of skin cancer, which is cutaneous squamous cell carcinoma. Let me just share my screen here. So as Dr. Sai mentioned, I'm a medical oncologist in the Department of Cutaneous Oncology. I've been at Moffitt for about 10 years now. This August will be 10 years. So this is essentially a broad overview of keratinocytic carcinomas, which are both squamous cell as well as basal cell. And these are essentially diseases of aging. So as we grow older, we have a higher likelihood of developing one or both of these cancers. And just to give you a sense of epidemiology and how often these occur, if you go back in time and look at 2019, just 5 years ago, we had about 52.5 million US citizens who are greater than 65 years of age. But this population is continuing to grow and is anticipated to be about 84 million by the year 2050. And it's also an important and sobering statistic that 1 in 5 Americans will be diagnosed with some form of skin cancer in their lifetime. Now, these are very common cancers, and because they are so common, they're not routinely reported to tumor registries. So we often have to try to infer how common they are based on what are called claims databases. So, for example, the Medicare claims database. So somebody gets a procedure done or a diagnosis code for a basal cell or a squamous cell. That data is essentially retrieved. And if you go back in time, over a decade ago, it was 5.4 million cases in 3.3 million people in the year 2012. But what's also tricky, as Dr. Arulu mentioned, is that with these patients, as they grow older, they have other medical comorbidities. For example, heart disease, diabetes, lung disease, kidney problems that could occur. And that in turn clearly impacts potential treatment choices that we have to offer these patients. So that is quite different from the other common disease that we treat at Moffitt, which is melanoma, the average age for melanoma tends to be younger compared to what we see in squamous cell and basal cell. So that's an important differentiation feature because we have to be cognizant of what side effects our treatments can potentially cause. This is a cartoon. Hopefully you're able to see the cartoon. The small, what it's pointing towards is a T cell, part of our immune system. And the larger cell that it's trying to destroy is the cancer cell. So this is, real world imaging through electron microscopy. And this is David versus Goliath. So from that standpoint, this is what we need to happen in a routine circumstance. But this doesn't always occur because cancer develops and our immune cells are not routinely recognizing those cancer cells and therefore not destroying them. This is an old slide, but it's still a very important slide because it tells us what typically happens when we refer cancer or cancer tries to develop and the relationship between cancer and our immune system. So you start at the bottom at number 1, bottom left, 7 o'clock, and you can see the tumor, which is sort of the tumor cells are occupying sort of the 4 o'clock to 7 o'clock position. And there are certain proteins on the cancer cells called cancer cell antigen that are essentially recognized by the immune cells. These are the dendritic cells and antigen presenting cells. And those process these proteins or signals, so as to speak, to try to tell the immune system, this is how you're going to recognize these bad cells. That in turn undergoes priming and activation. Essentially, those T cells that I mentioned earlier start getting activated. They traffic to tumor, so essentially gets attracted there. Those T cells then try to get into the tumors through the blood vessels and through various recognition mechanisms, understand that these are the bad guys and essentially try to destroy those cancer cells. Now, this is a very simplistic path that's drawn here in terms of a cartoon. But obviously, at each one of these stages, this is a highly regulated sort of pathway and process and potential for interference by us at each one of these pathways to hopefully augment or improve how our T cells respond. Why is that important? Because immunosuppression, so patients whose immune systems are not functioning too well, have a much higher risk of developing skin cancers, particularly the three that you're hearing about today, basal cell, squamous cell, and Merkel cell that I've highlighted in red. So for example, in an individual who has a solid organ transplant, a kidney transplant, a liver transplant, heart transplant, where they have to get medications to suppress their immune system, they have a remarkably higher risk of developing skin cancers, particularly cutaneous squamous cell cancer, almost to 100-fold increase relative to patients who are not transplant recipients. And the skin is, in fact, the most common site of cancer after a solid organ transplant, and within that, CSCC is by far the highest in terms of incidence. Again, this is a very simplistic cartoon of a T cell, the important immune cell that we want to function. But what you see on the left side are receptors that these T cells have that activate the T cell. And on the right side, you have receptors that sort of suppress the T cell function. And what the T cell eventually decides to do is essentially a fine balance between the activating versus the inhibitory receptors. And that's what eventually determines the fate of that T cell in terms of functioning. Now, all of these are under investigation, and the ones that we have actually developed drugs to try and, shut down those inhibitory receptors so that we can actually activate the T cell have been CTLA-4, PD-1, and LAG-3. Those are the three that we actually have FDA-approved drugs for in skin cancers and some other malignancies as well. And a lot of the others are still in the investigational phase. This slide is mainly to highlight what happens when there's repeated damage to the skin, for example, from ultraviolet light. What that does is with each damage from ultraviolet light B or A, which is seen typically in sunlight, the genome or the cells that get exposed to it on the skin suffer damage, and that causes DNA damage and eventually some very characteristic molecular changes. We call that C to T transitions, which on the left side of this graph are the light blue bars, and that's seen very, very commonly when we do when we test the tumor for molecular alterations, and very high numbers are seen in cutaneous squamous cell carcinoma. And what that means is that on the right-hand side, when you look at the number of mutations, we call that tumor mutational burden, and we can actually test that now on the actual tumor tissue itself. Cutaneous squamous cell carcinoma has a very high tumor mutational burden on an average of about 50 per megabase. And conversely, as a result of that, they tend to be very sensitive to immunotherapy because now the immune cells or the T cells have a larger repertoire of proteins to recognize because of all those multiple mutations. And so cutaneous squamous cell has a high response rate. Merkel cell, as you can see right in the middle on the top there, melanoma. So the revolution of these immunotherapy drugs essentially came from skin cancers and now has been extended to the other types of tumors. So this made a lot of sense that we should utilize immunotherapy for these diseases. But despite benefits to immunotherapy, we still have a lot of unmet needs. We know that these drugs work, and I'll show you a few slides to show that. But the question is, can we improve on those results? Because these drugs do not work for everyone. If they work in the advanced setting where somebody has disease that has spread to other organ systems or cannot be cut out with surgery, can we actually move it to earlier phases of the disease and try to prevent it from occurring after we've utilized surgery as our option as well? How do we account for some of these high-risk populations, such as transplant or other patients on immunosuppressive drugs? And then what's the appropriate sequence? Because we have surgeons, we have radiation oncologists, and we have medical oncologists, and all of us are going towards the same goal. But can we actually sequence these treatment modalities with better understanding of the disease? This was the original trial that led to the approval of a drug called cemiplimab, which is an anti-PD-1 immunotherapeutic agent in cutaneous squamous cell carcinoma. This was a large study that had 3 different cohorts. One cohort in the middle, cohort 2, was locally advanced. So these were tumors that were very close to vital organ structures and could not be cut out by surgery. Or cohort 1 and 3, where they had already spread to lymph nodes and other distant organs, most commonly the lung and distant lymph nodes. And what they tested was, what was the efficacy of cemiplimab in these patients? And the ORR stands for overall response rate. And you can see anywhere between 43% to 50% of patients responded. That means almost half the patients can actually have a very nice shrinkage of the tumor as we follow these patients with serial CT scans or PET scans. And at the bottom, what we see is, over time, almost 20% of patients, for example, in cohort 1 in the orange bar, actually had a complete response. That means 1 in 5 individuals, the disease disappears completely, which is quite remarkable for a disease where we really didn't have great treatment options previously outside of immunotherapy. So while these drugs work, or this drug works, the question is, does it last? And very recently, we published this earlier this year, and this was the long-term analysis of the likelihood that the cancer remains under control. So this was called progression-free survival. And essentially, you can see across the various groups that were here, this is data that's now going out over 36 months, over 3 years. So the higher that line, the better it is. So many of these patients respond to immunotherapy and, importantly, maintain that response. So these responses are durable. Similarly, there's a second drug called pembrolizumab that's also approved by the FDA, and that was based on this study called Keynote 629, originally presented back in 2020, 2021. And then last year at our annual meeting, ASCO, they presented a longer-term follow-up. And just the salient points are that, again, with locally advanced disease, patients can do very well. Response rates are 50%. With advanced disease that has spread to other organ systems, the response rates are not as robust. And unfortunately, those patients eventually start developing worsening of their disease. So their average survivorship is about 2 years. Again, that's much, much improved compared to less than 1 year when we only had chemotherapy, but it clearly tells us that we have more work to be done. And both of these drugs can be utilized. To me, it is 6 of one, half a dozen of the other, because both of these drugs potentially have very similar efficacy and side effects in this disease. So if these drugs work well for patients where it has already spread, how about trying to move it earlier in the setting where a patient may have a lymph node enlargement? Normally, those patients would go to the operating room, have the lymph nodes taken out, then would get radiation, and then would get sent to Dr. Erlu, myself, or Dr. Brohl, who you'll hear from later, to consider additional form of treatment to try and reduce the risk of the cancer coming back. But what we have recognized, particularly in our skin cancer patients, is that maybe giving the drug early, so prior to planned surgery in selected high-risk cases, may actually be better. So neoadjuvant stands for treatment prior to surgery or prior to an operation. In selected cases, not everyone requires that. The patients with early stage disease, early stage 1 patients, more than 95% of them will be cured with surgery alone. It's only 2 to 5% of those patients where the disease comes back in the lymph nodes or goes to other organ systems. But what this allows us to do is, if somebody has a lymph node in the neck, we can actually biopsy it. We can treat them with immunotherapy or even inject medications into that lymph node, and then take them to the operating room, assess what happened with surgery, and then decide, do they need any more treatment afterwards? So this was a very important study where we already knew cemiplimab worked, so now we moved it into patients who have high-risk disease, but theoretically, surgery is a very appropriate option for them. And what we did in this trial was give 4 doses of cemiplimab prior to planned surgery. And then the patient had an operation as long as they were willing to proceed with that operation. And then based on what they found at surgery, we decided whether or not to give them more of the same drug or consider radiation, or actually in some cases just observe. And the primary endpoint here was pathologic complete response, which means under the microscope, when those tumors were taken out, there was no evidence of disease. That means the drug really worked well. And so you can see 50% of patients had a complete pathologic response, which is quite remarkable, with just 4 doses of that drug. So in many of these cases, we just continued to follow them. without giving them any additional treatment. And this essentially was a follow-up of that same trial, and the 2-year event-free survival, that means the likelihood of getting to 2 years without the disease coming back or without any other intercurrent issues, was extraordinarily high. And of the 40 patients in this trial of 79 patients who had actually achieved a complete response, not a single one of them has had their disease come back. So it tells me that achieving a pathologic response actually helps us prognosticate that these patients potentially can hopefully do very well. So that's an important goal, particularly when you're considering preoperative treatment. So this is an example of one of my own patients. Preoperative treatment, what I'm highlighting on the left-hand side in the CT scan is a lymph node. You can see it marked with blue, and that's a lymph node that's in the right side of the neck. We gave this individual cemiplimab in the preoperative setting, and then after the cemiplimab, there was no evidence that lymph node had completely resolved. The patient did go to surgery to take out those lymph nodes on that side, and essentially, again, what we saw on the left-hand side was the biopsy, and you can see the cancer cells right here in the middle, which are on blue in that sea of pink in the back. And in the bottom section is the brown staining, which we call the P40 immunostain. And on the right-hand side, where the lymph node was actually taken out, and essentially there was just necrosis or dead tissue, but no evidence of cancer. So this was a pathologic complete response. So a success story. Similarly, this patient, you can see on the opposite side, is on the left-hand side. I don't know if my pointer shows up, but on the left-hand side is a lymph node, which in short order rapidly grew. You can see a much larger lymph node here. And then again, patient received cemiplimab and then completely disappeared. We don't see any evidence of that abnormal lymph node. So to ask the question, do we even require surgery for an individual like this? Is there any good way for us to tell, can we eliminate surgery? Can we eliminate radiation and only do selected immunotherapy? And those are questions that current clinical trials are trying to answer. So in fact, this was a small study from Australia, and what they tried to do was de-escalate from planned surgery and postoperative radiation. So these were patients who got pembrolizumab, the other approved drug that I mentioned earlier, where they had resectable but high-risk disease. They got pembrolizumab, and then if the patient on imaging had a complete response, then the surgeon did additional biopsies. If that biopsy was also negative, then the patient did not undergo surgery or did not undergo radiation. So we essentially eliminated 2 modalities of treatment. On the other hand, as if the PET scan showed there was still something that was lighting up there, then the patient went to surgery, and then we would decide based on what we found whether postoperative radiation was to be given. And the punchline here is that de-escalation from surgery and or radiation was possible in almost 2/3 of patients. So this group of investigators from Australia in a very innovative trial sort of tried to minimize or reduce the amount of treatment that we are giving these patients. And hopefully we can actually duplicate these results in a larger setting as well. These were 2 trials of adjuvant therapy. So this is drug given after the surgery has already been done. And interestingly, both have now been released as a press release. The first was Keynote 630, where patients with high-risk squamous cell carcinoma that had already been cut out, then they received radiation, and then half of them got pembrolizumab for 1 year, the other half got placebo, so no pembrolizumab. And unfortunately, last year through a press release, Merck stopped that study because it was found that it was a negative study. We're still waiting for the actual data. Now, on the other hand, the cemiplimab C-POST trial, we got results earlier this year in January, again, just as a press release, that the use of postoperative cemiplimab in selected high-risk patients, there was an inherent difference between the eligibility of patients on these 2 trials that may explain the differing findings, but this was indeed a positive study. There was a 68% risk reduction in the likelihood of the disease coming back, and which was quite remarkable. So we anticipate seeing data from this trial in the near future, and this will likely become potentially a standard of care. So I've shown you data on adjuvant. I've shown you data on neoadjuvant. This is one of the new studies that has just been activated recently through the cooperative group, the NRG, where patients are randomized with high-risk disease to either get standard of care surgery followed by radiation, or in the second arm, get preoperative immunotherapy and then limited surgery and then radiation, trying to determine, is it better to give the treatment before or after? We have a few trials at Moffitt that either have been completed or still ongoing. The Rampart study asked a question whether patients could get early versus delayed radiation when they're getting immunotherapy. What you see on the right-hand side in the photograph is a patient with a large, unresectable cutaneous squamous cell carcinoma. That these are patients where we would offer radiation to help control the disease, but also offer immunotherapy. That trial has completed. We are waiting for those results. We did a biomarker study. That means collected blood and tissue from our patients participating in that trial, giving preoperative cemiplimab for squamous cell or Merkel cell. And again, we are still analyzing some of that data. In the transplant population that I mentioned earlier, we have a very novel drug called RP1, which is a genetically engineered modified herpes virus. And it's injected directly into the tumor itself, where it multiplies and potentially causes an immune effect. And this is currently in transplant patients, and very early data suggests almost a third of patients have a nice response just to this, because we can't use immunotherapy for these patients for worry that they will fail their graft. Dr. Erlu's leading another trial, again, a novel epidermal growth factor receptor antagonist called afatinib, and we're almost completed with that study. But this builds on some of the observations that we've made at Moffitt, that these drugs can work even in patients that have progressed on previous immunotherapy. So more to come on that. And then this was another trial, unfortunately a negative study. We're still waiting for the final data to come through. And this was where we used immunotherapy with the same injectable RP1 directly into the tumor. So half the patients got cemiplimab alone, the other half got the combination. But the hope was that the combination would prove to be superior. But in fact, that was not the case. So longer follow-up will tell us whether this would eventually bear fruit or not. And then finally, for transplant patients, this is through the NCI CTEP. We have a trial of combination immunotherapy plus modification of the transplant medications for kidney transplant patients who have skin cancers. And again, hopefully building on some of the data that Moffitt had participated in previously. I'd like to leave you with this, that is a multidisciplinary team. That means folks from medical oncology, surgery, plastic surgery, transplant teams, dermatology, radiation, nursing, our APPs. We are all integral to the management of our patients, particularly in a disease like this where we have different treatment modalities. And it really is incumbent on us to come together and really treat the patient as a whole, rather than each one of us simply concentrating on our individual specialty. And I'm very proud to say that we do that very well within our team. We talk to each other all the time. We have tumor boards every week. And this clearly highlights the benefits of what I refer to as multidisciplinary care. And importantly, it is, and this data has been demonstrated, that incorporating the patient's opinion into this shared decision-making is critically important for patient satisfaction and essentially better outcomes. And in many of these cases, psychosocial support is also required for patients as well as their caregivers, because these are different diseases. Finally, non-melanoma skin cancer has an extraordinarily high economic burden because of how common it is and the number of patients, and each patient having multitude of these cancers. And this is, again, data from over 5 years ago. But what you can basically see is total U.S. direct cost in terms of U.S. dollars is about $4.5 billion per year in medical costs just for non-melanoma skin cancer. So this is, again, a common disease and a very expensive disease when you look at healthcare burden on the economy. And so importantly, prevention is critically important. Use that sunscreen, make sure that we avoid tanning, and certainly spread the word in terms of education. We're in Florida. We all love to be outside. We love going to the beach, but do that smartly and try to stay away from the sun, particularly during those peak hours from 11 a.m. to 3 p.m. So I'll hand it back to Dr. Sai for continuation. Thank you very much for your attention.